we record this, we've woken up to yet another scandal at the Kenyatta National Hospital. This time, the wrong patient went in for a neural surgery, as in to the brain, as in to the head. And in all of this, there was someone else who was supposed to have gone in, but that other person did not go in because there's something about files, and someone went in and they checked and they cross-checked, and you have no idea what happened except that the wrong person underwent surgery. The issue of their recovery aside, and obviously of the other person having gotten the surgery, our healthcare system just seems to be heaving. In fact, even worse, it seems not to be fit for purpose. If you've ever been to the Kenyatta National Hospital, the thing that will strike you about it is just how convoluted that system seems to be. You take in a patient, you're not very sure where you should be going, and then you need someone to stay with the patient while someone else goes to look for the right place to be, to how to administer, how to register them, and by the time you're done walking through what seems like miles of corridor, your person may end up in a bed with 2 other people on a waiting list for a week or more to get the treatment that they need. Heaven forbid if you decide to go the private way and you are not deep of pocket. It will probably take you maximum 2 major illnesses in this country before you have sold your house, put your land on mortgage, or you're facing near bankruptcy. In fact, to the point where, touch wood that it would never happen, but you're praying to the God, does this person really, if it's your will? You know those prayers. You know the ones where you're just saying, we're at the end now. Take this person. And these are some of the questions that we need to address if we are going to achieve, or if the government is going to achieve. Hi, my name is Renee Gamal. You're watching Focus on Capital TV. And we have in studio Dr. Oma Oluga, Secretary General of the KMPDU, the Kenya Medical Practitioners and Dentistry Union. First of all, hello.
Hello. How are you?
First, the obvious questions. Let's move those to one side. How do you operate on the wrong guy?
I think this is one of those that no one has said it was me, and everyone is saying it wasn't me. And that's part of the blame game that you're talking about. But eventually someone went in, the wrong person, and they had their brain opened. So how do you get there? 2 ways that you get there. One of the ways that you get there is that at Kenyatta National Hospital, on that particular day, and on every day that you go to Kenyatta National Hospital and you want an operation into your brain, they are, in the whole country we only have 16 neurosurgeons. Some of them work at Kenyatta National Hospital. And what happens is that every single day there's just one in theater, and then there's one in the casualty, and then there's one in the ward. So the doctor who sees you may not be the doctor who is going to operate. That's not necessarily a bad thing. But then if in between, in the movement of patients, in the movement of files, in the movement of these x-rays, anything slight changes, then you end up with an error such as the one that we got. And I think we have acknowledged as the fraternity that there was a mistake. This was a medical error and it should not happen again. So I think that that's how it ended up being the wrong patient, because and one of the things I need to add is it's easy to think how. It's because these patients, both of them, not named, not talking, then they have a file, and then it's just the documents that change, and then there's no other reason to believe that this is not the right patient, because
this is not the right patient.
When
for the
you
file.
see a patient and you examine and you do all those things that we do as doctors to try and ascertain, all these patients have the similar characteristics. in all this mix-up, you have the right file, the right X-ray, the right tag, you know. So as a doctor, you're looking for this bleed in the head, and you're not finding it, but you're seeing it on the X-ray. So you're like, where is this? You know, and you open up and you find, no, there is nothing here. And then you raise the alarm, you call back the ward, and you're saying, are you sure you have brought the right patient? And then they say, yes, we have brought you the right patient. And maybe in their opinion, yes, they have brought you the right patient. So some of those are the mix-ups that we are saying is a failure of quality assurance, is a failure of the system. It's medical error. It's damn serious. And I think then the public are wondering, why is there no one taking responsibility? And I think that is the challenge. That's the outrage. That's the sensationalization, because we as a doctors are saying it's a medical error, but it's not necessarily negligence. And we think that it's not necessary that someone needs to take responsibility. We just need to improve the system so that something like that never happens again.
Is there a systemic problem in the admission, the registration, and the movement and management of patients, so that this was just a matter of time?
In hindsight, I would say yes. It's as you mentioned, it's convoluted. It's a system that even for us who work there, sometimes we don't understand. Sometimes you get frustrated. Sometimes you want to give this patient blood, and you order for blood, and you do all the tests, and 2 days down the line, the patient has not received blood because another patient who needed blood actually got the blood. And you know, and it's that messy sometimes. I think you and I, even myself, when I take my relatives there, I see the convolution. You have to move from one place and follow the labs and go to a different lab. And if you most of the time, if you look at the lab request, and specifically for me, I hope other doctors do, I write there, send lab request to self. Self means at the patient, because that is the surest way that the patient is going to pick their own results. Sometimes if you write the ward, like this patient is going, the results should come to this particular ward, the results would be missing, or sometimes the results would be changed, because all, you know, it's quite a mixed system.
Should everyone go right the way from the board right down to everyone who is not an actual medical service provider or ancillary service provider?
Kenyatta needs serious restructuring. And if I were on the other side, if I were I don't know whether to say a politician or a manager, I think I would do a clean sweep in Kenyatta.
We now have the big four, one of which is universal health insurance for Kenyans. But is this throwing money at a problem that needs more than money?
So far, it's just political commitment. So far, it's just talk. No money has been thrown that way. You know, first, many people have asked this question: how did we get to the big four? I think that question has not been answered. But for us in the medical fraternity and in the healthcare specifically, we are very happy that, you know what? The president chose universal healthcare. That's a big thing. That's a big opportunity. We want to ride on that political commitment. We want to ride on that pronouncement. We want everyone to align to how do we achieve universal health coverage? How do we help our people? Because we also believe that the president didn't just make this mention because of there's some politics. I think the president is also tired of being called to Harambes.
As are the rest of us.
As the rest of us, you know. Because each one of us had to contribute, sell something just to get someone care. And sometimes we get this care, but our people still die. So we end up losing a lot of money, being thrown in too late. And I think looking at his population, we are the citizens of Kenya, I think he felt that the best thing he can do for them is to help them afford the healthcare. And I think it's a brilliant idea. But then the budget policy statement for the Ministry of Health, the allocations for the Ministry of Health hasn't changed. But I've seen a few discussions, and they are thinking about doing a sin tax. Sin tax means that they are going to tax more on alcohol, tax more on tobacco, tax more on what they consider harmful products. The other thing is to group in health insurance so that health insurances are working for either specific populations or for specific hospitals. So we could look at some of those ways of trying to say that if you have this kind of insurance, then you go to this specific regions, or this specific or this specific population, or looking at you can also categorize employees or families.